So, assalamu everybody. Tanveer Rab from Emory University in Atlanta. We have been here for about 30 years now, almost towards the end of my career with them the next few years. But so the Emory is a great place to work with. It gave me a great opportunity to grow and do a lot of publications and make some contribution to cardiology. So I'm on the ACC AHA guidelines committee, writing guidelines committee. These documents are always reviewed by the committee before they're published, and the next year or two, you get to have the authorship on major publication, the guidelines. But we review all this before we publish it and give it out to the community at large internationally. So as you know, this came out last year, and these are the revascularization guidelines. And specifically, we'll talk about left main and multivessel CAD, with the important thing being, when should you do CABG, when should you do PCI? And this was changed quite a bit in this particular publication compared to the prior publication almost 7-8 years ago. So this is the way it's published out, as you know. Both the ACC and American Heart publish it, and we have a long list of people who write it and a list of committee members reviewed, including myself. As I indicated, all of us have to review it, provide our comments, edit the papers, and then keep going back and forth to publish it. We have decided that we'd try to make this process much shorter, probably try to do it within a year, and then give yearly updates online on important changes that come up. So it's not a document that lives there for about 7-8 years and renewed, but it's a living document, so as to speak. So important thing about CABG is that how do you predict risk of death with CABG? The first thing is that it's a class 1 guideline. Then patients have been considered for CABG. Calculation of the STS Society of Thoracic Surgeon risk score is recommended to help risk stratify patients. It's a great online tool that's available. And then the other thing that we talked about is defining lesion complexity, calculation of syntax score, which, as you know, is a synergy between PCI with taxes and cardiac surgery score. And it's not a class 1 recommendation. It's nice to have a syntax score. So when you look at an angiogram, it'll be helpful to do the syntax score to assess lesion complexity. Because as you know, the scoring of the syntax is low, intermediate, and high. And low to intermediate scores can do equally well with surgery or PCI. But high scores lean more towards surgery. So let's talk briefly about left main disease. So initially, the left main treatment was with CABG versus medicine. And in 1976, initial results of subgroups showed clearly that the mortality at 5 years was lower in the CABG arm versus the medical arm, 20% to 36%. And the 38-month mortality, just 36-month mortality in 3 years, really, the CABG arm was much, much lower, 7% than leaving people on medical therapy. In fact, the death rate at 1 year was greater than 50%. And then in 1982, there's another publication that showed the outcomes with left main stenosis severity. The higher the stenosis, the greater than 75%, the mortality survival was lower than medical arm versus the CABG arm. For the intermediate stenosis, it was quite close, but certainly with a high degree of stenosis, survival is better with surgery. And then from the CAS or coronary artery surgery registry over time, remember there weren't any PCI trials then, all compared to medical therapy. That asymptomatic left main coronary disease, the survival was lower with medical therapy or surgical therapy. And the curves, obviously, with no left main disease, survival was high. With left main disease, with dominant left circulation, the survival was lower. So clearly, When you have no left main disease but have multivessel disease, your survival is better than with left main disease. So, so the most important thing in revascularization was in cabbage versus no cabbage trials in the 80s, when before even PCI came into prime time, that the extension survival was the best, not in one vessel disease where people could do well medically, but or three vessel disease, but in left main was a big advantage that you could extend your survival by revascularization in a group of left main disease. But again, to emphasize, these are all cabbage versus medical therapy trials. So cabbage became then the gold standard for left main revascularization, and we thought that it was the best strategy for left main till recently over the last decade. Remember, the left main is the largest coronary vessel that you should have, and newer techniques with stenting and all have proven that this is an easily accessible target where you can, if you do the technique in the right kind of manner, you will have very good results, sustainable results. But the cabbage gold standard for left main revascularization provided a Lima to the LED graft was used. If you put a vein graft in, your survival with vein grafts is not as good as a Lima to LED graft, and this has been proven over the last 20, 25 years. So the Lima, for a conduit, Lima to LED graft is the best graft, and we as interventionalists should understand the Lima graft is superior to PCI for complex coronary disease. So what is the long-term outcomes of left main stenting, drug stent versus cabbage? And as you know, the lesion subtypes are the ostial left main or shaft mid-body. And over here, from the old Delta registry, it was low syntax score. So if you have isolated disease, syntax score would be less than 10 or so. Your target lesion revascularization is very low, 4.5% at 3 years. When I started doing left mains, it's really the surgeons who started sending me these patients because they're putting grafts in and for ostial left main, and some of these grafts are not doing well, including Lima to LED graft, and part of that was competitive flow that still remained in the native circulation, and so the graft could deteriorate. But for the ostial and shaft left main, surgeons started giving me patients to do these because they could be so ideally done in these locations. Certainly for these, I really think that the left main PCI is superior. Distal left main bifurcation is more complex. It involves 80% left main lesions. The more recent study said it's probably closer to 60%. So PCI using DS is associated with a higher rate of TLR, and that has been shown in many registries, including more recent ones, such as Excel and Noble. So what are the clinical trials of left main PCI with DS? Of course, the syntax left main, pre-combat, Excel, and Noble. I won't go into that in great detail, but long-term mortality, we're talking about 5 years plus, and the syntax score was PCI versus cabbage at 5 years was very similar, very for syntax and pre-combat, and even for Noble, but for Excel at 5 years, diversion started to take place where surgery appeared to be better than with PCI. And the time to curve event for mortality for left main stenosis of 5 years, again showed a diversion, not early on in Excel, 3 years, but Excel was the outlier, that PCI had more mortality than cabbage. And outcomes of cabbage versus left main PCI, I won't go through all this, but it's mostly on how MI was defined. This is not really the purpose of this talk, but let's talk about meta-analysis of left main trials at 5+ years follow-up. And the most important thing is that all-cause death appeared to be very similar in all trials, except the outlier was maybe Excel and another trial that was undertaken with previous generation stents in 2011 by Baudreau et al. But there's heterogeneity due to Excel. If you removed Excel as a trial, I mean, there was no real difference between DS and cabbage. Now, in 10 years now, the results have come out for syntax that the curves are very parallel, for cabbage and PCI for mortality, for death, the most important event in your life, death, or terminal event in your life, death. And then in the pre-combat is very similar. So for long-term trials at 10 years now, and Noble and Excel have not gone up to 10 years now, the mortality was very similar from these two trials. And 5-year and 10-year mortality rates are very similar. So left main PCI then it becomes an acceptable alternative to cabbage, the gold standard. Remember, the cabbage was always versus medical therapy previously, and we kept on looking at this data that the previous studies all showed comparison with medical therapy was not that good. Statins were not available. P2Y12 inhibitor is not available. I mean, all those things were not available at that time. And even in the medical therapy arm, and medical therapy has really gotten very good now. And the PCI with DS versus CABG shows comparable safety in patients with left main stenosis, particularly in the low to intermediate complexity. However, repeat vascularization is more common. So let's go through what we should do about these patients. These should ideally be discussed in a heart team approach. We still do that. So PCI has early advantages, less invasive, fewer peripheral complications, lower 30-day MACE, and rapid recovery of angina. CABG has late advantages, particularly durable limited-LED, not the vein graft group, but the limited-LED, and fewer adverse effects beyond 1 year, particularly MI and repeat revascularization procedures, but there's no long-term difference in survival. So we recommend very strongly for complex left main disease should get the surgical recommendation from the heart team approach, and patients with optimal therapy is unclear. Heart team, including interventional cardiology, cardiac surgery, and even clinical cardiology, is recommended to make the best decisions for the patient. So selection of the strategy is very straightforward. If you have unprotected left main disease, particularly low to intermediate syntax score with isolated left main plus one vessel disease, both options are pretty good. Recognizing there's a high rate of repeat revascularization, the PCI arm, and the lower rate of repeat revascularization in the bypass arm, but overall safety or mortality is very similar. So for the unprotected left main, I think the ostial shaft left main should be extended with an excellent long-term outcome. For the patient distal left main bifurcation lesion, the low to intermediate syntax score, ideally heart team approach should be undertaken, and CABG versus PCI discussed with the patient. And for the surgically ineligible patient, PCI is a safe option. Proper techniques, and I will emphasize that, proper techniques of left main stenting can produce an excellent outcome. So what then happened because of all these trials that previously we recommended in 2009, we gave PCI class 3 a no for left main disease. Now we've been able to change it, the current data, to 2A for PCI, and that's a big jump. And this is one of the most important aspects of this revascularization guideline, that we're able to change from a class 3, which is no, which has legal implications, particularly in the US, the why you're doing procedure with a class 3 indication when they, particularly if there are adverse outcomes, we're able to change it to 2A, with a body of evidence is sufficient to tell you that that PCI had advantages. So that's where we are with the US guidelines. So revascularization should be given in left main therapy, the stable ischemic heart disease, to improve survival compared to medical therapy. And so CABG is 1 and PCI is class 2A. So, this is an important graph where if you just to look at stable ischemic heart disease, and then there's indication to improve symptoms. If they are refractory angina, should revascularize. If you don't have refractory angina, maybe medical therapy is good, except in the subgroup of left main disease. And if you have left main disease, if there's a high complexity, you should think about CABG. After heart team discussion, however, the complexity is low, you should think about PCI. If you do not have left main disease and you have multivessel disease, with anatomy suitable for PCI CABG, and you don't have good anatomy, you have complex disease, but it's multivessel without left main disease, guideline-directed medical therapy is a good option. If you do have multivessel disease, low EF, then you should think about CABG. EF is less than 35% definite CABG, EF 35 to 50% probable CABG class 2A. If the physician is not a suitable candidate for CABG, even in this group, you can think about guideline-directed medical therapy without PCI. If the EF is less than, it was over 50%, this is the other big recommendation in our revascularization guidelines, that if you have EF more than 50% and have triple vessel disease, both CABG and PCI are equivalent. And this is where the surgeons had a big problem with the guidelines, where this is a big change, where people with triple vessel disease, not involving left main, being sent to bypass, and the surgeons always felt, despite the surgeon being a lead on this paper, that surgery is superior. But where's the data? This data was always comparing with medical therapy, never compared PCI. So based on more recent trials such as ischemia, etc., and courage, we came to the conclusion that for people with normal EF and triple disease, both CABG and PCI are equivalent options, giving them a class 2B recommendations, where the initial therapy approach should still be guideline-directed medical therapy, just because medical therapy has gotten so good with statins, P2x12 inhibitors, beta blockers, nitrates, etc. In the real world, however, surgically ineligible patients are the most common reason for left main PCI, okay? So surgical turn down was a big part of my practice, where the surgeon did not feel the patient was eligible for surgery, bad lungs, end-stage renal disease, cancers, advanced age. So I benefited a great deal from surgical turn down. But clinical trials do not include these patients. And for example, this is a female, the first picture here, it was 89 years of age, with severe COPD and has shaft left main disease. No other disease elsewhere, great candidate for left main PCI. On the other hand, if you take somebody who's young, this is a 45-year-old patient who had cancer with the expected life expectancy around 18 months, and he has a traffication stenosis. He was sent to me for PCI, and actually he survived all chemotherapies, lived through 5 years, and he got left main PCI. Now, this 70-year-old patient, multiple myeloma, lung cancer, and DVT with rest angina. So we got 2 cancers, myeloma and lung cancer. Life expectancy was 12 months. RCS, CTO, and distal left main traffication, stenosis, calcification. This was the kind of case that I got to do, and he survived actually 18 months. So what about multivessel coronary disease? Let's see, are we keeping track of time? No, we've gone over time. So, so CABG with stable ischemic heart disease, multivessel CAD, and normal EF has been downgraded to 2B for both CABG or PCI, as I just talked to you about. And for what about CABG with medical therapy with stable ischemic heart disease, multivessel CAD, normal EF? The effect of coronary artery bypass graft on surgery, medical treatment arm versus CABG arm. You know, CABG initially did well in terms of survival, but actually it caught up at 10 years to be equivalent. And all of these studies show that unless you have left main disease, at 10 years a catch-up for patients who are on medical therapy versus surgery, with surgery showing enough initial benefit of survival, catching up, it could be equivalent to medical therapy down the line. So let's leave all that. So the new class 2B recommendation represents a downgrade from class 1 recommendation 2011, reflects new evidence showing no advantage of CABG or medical therapy alone to improve survival in patients with 3 vessel CAD with preserved LV function, no left main disease. The older recommendation was based on evidence from registry studies, meta-analysis, and a single randomized controlled trial which was done in the 70s, all of which we completed 20 to 40 years ago, before the development of neurosurgical and PCI techniques or advances in medical therapy associated with improved prognosis. So basically, in the syntax scores, low scores favors PCI and high score favors CABG. We know that. And the 10-year survival, you know, on high syntax score, I mean, mortality in PCI versus CABG is greater. Serious events with PCI versus CABG is greater. Repeat revascularization in PCI versus CABG, but the lowest scores, mortality is equivalent for PCI versus CABG for all events, including mortality, serious events, and revascularization. So in patients with complex disease, in patients with cardiovascularization, significant left main CAD with high complexity, probably for very complex disease and high syntax score, again, as I said, CABG is better than PCI. In patients who require revascularization for multivessel disease with complex CAD, syntax greater than 33, with high syntax score, probably better thing about CABG. It's a class 2 recommendation. How about low EF? Patients with stable ischemic heart disease and multivessel disease with low EF, CABG appear to improve survival. And survival, really, the big benefit is the left internal mammary artery graft to the LED to improve survival. And the STITCH trial showed you, again, that in ischemic cardiomyopathy, initially there was no difference between CABG and medical therapy, but long-term CABG appeared to do well. And again, the hospitalizations also improve over time in the CABG arm with less hospitalization versus medical therapy. What about diabetics? In patients with diabetes, this is a multivessel disease with involvement of the LED for appropriate candidates for CABG. PCI is superior in diabetics with LED. And if they're not candidates for cabbage, but amenable to PCI, PCI can reduce long ischemic events. But in patient diabetes, left main stenosis with low to intermediate complexity, the rest of the coronary anatomy, PCI may be considered an alternative to cabbage to reduce major adverse events. But in diabetics, think about surgery with LAD, particularly if LAD is involved. And I'm going to stop right here because we really need to discuss cases, okay? All right? And so we'll stop.
Sounds good. I think, we can take another 10, 15 minutes easily if you, in terms of the cases. How long will the cases take? Otherwise, we can have a discussion around 7:35, 7:40. So you can continue the talk and then show the cases, or you can start the cases now, whichever way.
Okay, I'll just tell you the conclusion slide from this. Let's see. That the bottom line is, from all these trials, you should know that PCI does not reduce mortality. In older trials, outcomes of cabbage were compared to medical therapy, and modern therapy was not available, such as PTY12, ACE inhibitors, ARB, and statins. Cabbage has survival advantage left main stenosis at that compared to medical therapy. And there's no survival advantage of cabbage or PCI. It's stable ischemic heart disease. We're not talking about STEMI or ACS. Particularly stable CAD, including left main stenosis, low to intermediate syntax scores. Cabbage has no advantage of PCI, okay? And for patients with diabetics, Lima to LED graft is superior, putting in diabetics with low EF, okay? So let me stop sharing it.
Yeah, that was a nice take home message. Excellent talk and covered all the aspects very nicely. So I guess with cases, we can see some practical application of the guidelines.
Welcome. I'm sorry I've just joined a little bit late, Nouman.
Nadeem, right?
Yeah.
So, Professor Tanveer Rab just finished up his talk and he's going to go over some cases, and in the end we'll have a discussion.
While he's waiting for the cases to start, can I just ask a simple question?
Sure, please.
Yeah,
Please
the question is this mortality thing with left main. Did they analyze that why is mortality better, or why is mortality with left main stenting? Is it because of concomitant disease in those patients? Are those sickers, or were these cases where there was a certain, were there cardiac deaths in the group where the PCI was done in left main? Was it left main restenosis leading to sudden occlusion, or why is, or were they, what about isolated left mains compared to cabbage? Were the subgroup analyzed and seen? Because I always feel that if there's a 12 millimeter plus area, or 4 millimeter stent in the left main, it shouldn't be increased mortality in this group.
So there isn't. I mean, an isolated left main disease, there is not any increased mortality compared to cabbage, okay? And with low syntax score, even with complex lesions, all these trials, syntax and pre-combat have shown the mortality is very low. The chance for stent thrombosis is actually very low, particularly in the first month and the first year. And that's why I think if we continue DAPT, this was discussed just in the bifurcation club, if you continue DAPT for a year, but there's no trial yet, an adapt trial for just for left main bifurcation, it appears that the chance of thrombosis is extremely low and the risk of restenosis is very low, except in the side branch, which is circumflex ostium, which is still about 9 to 11% or so for restenosis, but not stent thrombosis. But if we do a good job and follow the technique step by step with no shortcuts, even in the provisional or stepwise provisional approach, or the 2 stent techniques, you follow each and every step correctly and get good left main areas, as you're talking about, more than 10 and 11, at the distal left main, at the bifurcation, at the polygon of confluence, you really should have very low restenosis rates. And then the other things, compliance issues. Patients must comply with dual antiplatelet therapy.
So this is what I'm asking. So why is, what exactly did they find out? Why is the mortality in your view higher in the PCI, let's say a high Centix score, is what's the actual cause of mortality in this?
In the high symptom, the lesion complexity of the residual disease that drives the death. So in all these trials, it's not the left main stenting that caused the death. It appeared that progression of lesion at other sites was the cause of death, particularly the PCI arm, not left main stenting alone.
Yes, so it was the distal working graft compared to progression of disease in distal vessels or lesions that were left alone. Those progressed further and they caused the increased mortality compared to the ones that.
So spontaneous. So remember there's a group called spontaneous MI group. There's a big basis of conflict between surgeons and the physician and the medical trialists in the Excel trial. The spontaneous MI was due to plaque rupture at other sites, particularly people with complex disease and who are diabetics. So lesion complexity, but remember, diabetes is not one of the confounders, both in Excel and Noble, just spontaneous plaque rupture due to the presence of multivessel disease with plaque in other situations.
Are you ready with the cases to share, or?
Yeah, please start the cases.
You have the. So you have some cases.
Yeah,
we can continue the question answer.
But there's one quick question about imaging. Look, imaging is an absolute must in left main disease. Over and over again, the emphasis with all the bifurcation clubs and everybody else, even now, that you have to have imaging to know how big the stent can expand and what is the residual area that you have after it. There's one area that there's no excuse not to do imaging. And I understand your resources may be limited, and you say it looks wonderful and beautiful and it looks like a huge left main. But I can tell you over and over again to all the trials from all different parts of the world, imaging was very important in improving survival in left main stenting. Okay, if you don't image, you have a higher mortality rate versus those who have imaged. From De La Torre Hernandez's work to the work done by the Koreans and work in Excel, over and over again, the repeat of the same thing. And we're going to come out with a guideline very soon that will tell you that imaging left main will be a class 1 indication, not a class 2 indication. So I understand the use of resources, but I think it's very important to know that. I mean, there's no deviation from that. All right, who has cases? Is somebody going to present cases or?
No, actually, I thought the talk will be with the cases, but I think we can continue the discussion with the.
No, you didn't ask me to showcase. I thought somebody would be presenting cases.
That would be fine. That would be fine. That would be fine. I think we can just continue this way with the discussion. And now, what are your thoughts on the Revive trial recently done with PCI in patients with ischemic cardiomyopathy? We were all optimistic with viable territory. Even there we didn't see benefit. Your thoughts on that? And stable patients, they were all basically patients who had no angina essentially and were doing well at class 1, 2 symptoms. So they were a stable group of patients. So in that population, we didn't see any advantage. So your thoughts on that trial recently came out?
I think we reviewed that in Journal Club, particularly the ACC. We did that recently. And there's several thoughts. I mean, and we brought the BCIS investigators in, and the Mamas was part of that too recently. So main thing was that how sick were the patients really? So several things were not done that we would do a little differently. For example, right heart caths were not done in these patients with low EF. I mean, were the patients optimized completely or not? I remember in part of the trial, somebody just measured central venous pressure, not really put a Swan GANs in. So how sick were the people? EDP measurements are not given. EDP, so people have good to normal, low normal EDPs, they actually do very well versus those who do high EDPs, okay? So clinical selection process, when it comes to stenting, they were stenting either 1 or 2 vessel disease, but not more than, so the majority of people got two stents. And third, the other thing was that, were they really optimized completely in medical therapy? And the use of mechanical circulatory support was very, very low. Okay, so all these confounders were there in the presentation on this paper. So, but then that really puts a twist in the whole thinking about what the guidelines just came for the guidelines committee after revived. Should we change the guidelines now? Because we just said that people low EF will benefit from cabbage with the Lima to LED graft. But the issue is Lima to LED graft is not going to work if there's a large area of anterior wall akinesia or apical akinesia. You can put as many grafts as you want. It's not going to change anything there. And the other issue that we talked about based on the revived trial was this other trial that's coming up from Abiomed, where they are actually putting in impeller devices for patients with low EF and doing PCI on them, okay, and looking at the outcomes. So all these variables are going to put in. I'll tell you this much, that if patient is well optimized in medical therapy, and Washington Hospital Center did a great review of 2,000 patients where they said, hey, if you wait and optimize the patients and then think about revascularization, particularly with PCI, you don't need mechanical circulatory support. So all that thinking is going to change. Hey, do we really do these people with mechanical circulatory support, with impeller or not? But, and that's why the impeller people are really having difficulty, because it's just a doodle poll that came out from Greg Stone on Twitter. If you interventionalist, would you really want to enroll in this trial, or do you think patients will do just as well without mechanical circulatory support and PCI of appropriate lesions? So all those things are up in the air as question mark. But certainly revived has deviated from the Stitch trial. If you think about medical therapy versus cabbage, and now PCI versus cabbage, I mean, all these things require a lot more thinking before we think, hey, it really doesn't matter whether you do PCI or cabbage.
In your practice, if you see somebody with ischemic cardiomyopathy who says, I'm doing fine, has got class 2 symptoms, would you offer him revascularization? There is no mortality advantage, at least in those stable, really good stable patients. I know all the confounders that you mentioned, but at the end, So would you offer him revascularization?
Probably not, except the number of patients with left main disease in the revived trial, I think excluded left main, remember?
Oh, obviously, excluding left main.
No, probably not. I mean, people are doing well. Why instrument them, I mean, if you're not going to have
on that note, in terms of, we see it all the time in practice regarding issue of complete revascularization. I wanted to switch gears to that. Just yesterday, the patient came to me, said, I have gotten 3 opinions so far. One person told me get a bypass, the other told me get a PCI, and one told me get medical therapy. And all my arteries are blocked. That's the general public thing. So I'm all confused what to do. In Pakistan, people are going to different people. And the gentleman the story is he's in his 60s, normal ejection fraction. He have a greater than 60%. And he had a tight, heavily calcified lesion in his mid-LAD. And severe stenosis is circumflex, dominant right, which is okay. And he has class 2 angina symptoms. He walks a mile every day, and he's doing fine. So, he was advised, we're tight LAD, tight circ. And since it's complex, it will need road ablation step, go for PCI. And, we said, there is an option for, if you want to go for rota and, PCI with that is an option as well. But if you do medical therapy, that is reasonable. And I think all 3 options are good. For symptom improvement, you can go for revascularization with preference to cabbage because of the higher syntax score. But then you get patients with multivessel coronary artery disease, where you have a patient with a CTO in the right and a focal lesion in the LAD. And he's having symptoms from that. Class 3 symptoms. The most of the symptoms are from the LAD. So easy way out might be that you fix the LAD and the symptoms get better and leave the CT of the right. Are you going to change his prognosis by tackling with that CT of the RCA? I mean, before the ischemia trial and, the teaching had been deal with a complex lesion first, so that if you can't take care of it, refer them for cabbage for complete revascularization. I mean, I would have, before the ischemia trial, I would have done the CT or RCA first. If it can't get open for some reason, then, for complete resistance, send him to cabbage. But now with this ischemia trial, do we need to subject them to going for bypass if it's not having an impact for mortality? Or make them go through complex procedure with rotablation? So that's something which, in both, if you could just stress and explain both the case scenarios, that'll be nice.
So in stable ischemic heart disease, we looked at all the data over and over again, and that's where the surgeons have differed from us. So we had downgraded everything to a class 2B for both PCI and CABG, that they are more, so it's not a class 1 recommendation anymore. I think a surgeon, that's where the surgeons disagree with us, okay? But where's the data? Data was, CABG versus, medical therapy, or PCI versus medical therapy. But if you look at the medical therapy arm, people do just as well. If they have no symptoms, good medical therapy with statins, beta blockers, nitrates, ACE inhibitors, dual antiplatelet therapy will do just as well. Unless you're very symptomatic, what are you trying to prevent? Death? Never been proven that you can reduce death in multivessel disease by any of these arms, okay? The mortality remains unchanged. So that's the goal, preventing death. Medical therapy is just as good as the others, okay?
So in that patient that I mentioned with the CTO of the right and the focal lesion in the LAD, now if he comes to you just for improvement in symptoms, would you tackle his CTO of the LAD first?
So yes, if you go back to
aim for complete revascularization, or would you just fix an easy
if it's symptomatic improvement, if for example, this young guy who gets angina running a mile or something like that, or he gets angina, say, going up a flight of stairs with chest pain, yeah, he can do well with you if you revascularize his LAD and he'll be angina free. So you can get symptomatic improvement. Once again, PCI does not change mortality, okay?
Absolutely, but I'm just being specific to this case. If you see it in your practice that he has a CTO of the right and focal lesion in the LAD, would you do the CTO first, or would you tackle the LAD first?
I just do the LAD.
See how he does. Fix the LAD and see how he does.
Yes, that's what I'll do personally.
Because the argument about complete and incomplete revascularization, the observation trial, the registry data has shown that with complete revascularization you may have better, but again, no randomized trial on this issue of complete.
And again, the CTO operators all over the world have tried to show through trials that there's improvement in survival, which has not been the case. The only thing they've done is improve the quality of life in terms of how much angina you get, whether you reduce the number of drugs you take for relief of angina, and whether your things like 6-minute walk and all that stuff gets better or not. It's a quality of life improvement, okay? Now, the case scenario that you just presented, Nouman, fix the LAD and the symptoms get better, fine, leave them alone, It doesn't get better, but yeah, there's a group of people, including at our center, who want to revascularize everything, but you need to know this, that we call that pidloplasty. Fixing small diagonals, small PDAs is not going to improve survival in patients, okay? It's a main trunk disease that you need to fix. And majority of the CTO trials have involved the right coronary artery because that's the largest vessel that seems to get occluded and people have beautiful results from, It has been shown though in the CTO trials that if you may have improvement, if you fix an LAD CTO. So the only group of CTOs that really helps, it seems, is the LAD CTO, not the right coronary CTO. So if you extrapolate all that, I don't send everybody with CTOs for CTO intervention. I say, okay, let's fix the LAD, see how you do, okay? But if you have heavily calcified LAD, you're symptomatic, roll out and fix it, and see how you do and bring them back if needed. I hope that answers your question.
No, you did very nicely. Thank you. So we have some questions over here as well. And then expert.
Let's see what the questions are. Let's see.
Well, we have a question from Mr. Mazhar CABG with total arterial grafting versus PCI / CABG with vein graft versus PCI and diabetics. Are both types of CABG superior to PCI in case of diabetics? Any known data?
So actually, you're going to get this answer in AHA coming up. It's coming up in a few weeks. In AHA, you'll have this answer, this question. I don't know the results of this trial.
The recent revascularization guidelines did give a preference to complete arterial grafting. I mean, as much as arterial grafting you'd get over the venous grafts.
Correct.
But that is not a routine practice that the surgeons have switched over. Most surgeons are still, doing Allama and vein grafts.
So in a young person, you should try to aim for total arterial grafting because we know veins don't do well, okay?
Yeah.
At Emory, we have a sort of a hybrid approach because we have robotic surgery and all that available. We'll fix something with the Lima to LED graft and then fix the rest with stenting because that's superior to vein grafts. The big hooker here is the radial graft, okay? I think both mammary conduits are good at the expense of mediastinitis and sternal dehiscence in diabetics, okay? In non-diabetics, that's less of a case, but if you have a high wound infection rate in your center, if you use both mammaries, there's high chance of mediastinitis and sternal wound dehiscence, okay? Now, the radial is a great confounder because that's the third conduit you need to use, and AHA will give you an answer to that, you know, whether it works well or not. So yes, total arterial grafting in a young person with severe complex disease with a lot of angina, particularly in diabetic, is the ideal way to go. But do we have a trial to prove that? We don't, okay? So, but I think we did suggest that the arterial conduits give you longevity. Let's see. Next question is from Rafiullah. You mentioned provisional disc left main. How much dedicate physiology to look at the side branch? Okay, so this was just coming back from the European Bifurcation Club meeting. The guidelines don't address this per se, okay? But from the European Bifurcation Club meeting, this is the following thinking. Any lesion length less than 10 in the side branch, well, for stenosis less than 50%, probably does not warrant any intervention. If the stenosis is more than 50%, even if the lesion length is more than 5 millimeters of osteum, the current provision strategy is crossover stent, okay? And they've introduced this concept, which has not really come up, is do a pot, okay, in the left main. And the stent struts go and open up into the bifurcation, and they can take care of the osteal stenosis, okay? And by just the stent struts sparing the side branch. But they've also now included the concept of distal optimization technique of DOT. So after you pot, because you can get a bottleneck step of the osteal LED, actually go fix that with the DOT, distal optimization technique, and then come back and redo repot. Now in side branch physiology, if there's an intermediate lesion, and I'm not happy with it, whether it's a short 5 millimeter lesion or long, yes, I will probably do a pressure wire and see what the significance is, okay? But will that change my technique? Maybe not. Now the issue about kissing balloon technique in provisional stenting is very controversial. Most of the data, particularly from Excel and now from the Korean registries, show that kissing balloon inflation versus no kissing balloon inflation has equivalent outcomes. So a lot of operators will basically do a pot and brief side-bar dilatation with a very short balloon, you know. There's a study in EBC that came out that a balloon length of about 8 millimeters or so is probably ideal to open up the osteal side branch, because most balloons longer than that is sort of straighten up. When they straighten up, they pull the stent struts from the other side, okay? And then you'll have to go back to do a kissing balloon. But they did an ultra short length balloon. And in that case, Mersato and all did that from Japan. They used a 8 millimeter glider balloon in the side branch, which to open up the side branch stud, and found there's less incidence of pull from the opposite side based on OCT and imaging. But yes, if there's the intermediate stenosis I'm concerned about, I will do a pressure wire, okay, to see if it needs anything being done or not. Whether I intervene or not, I'm generally a believer in provisional and stenting of just potting it, leaving it alone. Though in a few cases you'll see the stent struts cause a fenestrated stenosis, but they're far and few between, and people will come back with symptoms. But some operators like to open up the struts, just say, hey, this large circ or dominant circ. It'll make easy side branch access later on. Putting a group in Massey believe that, and they will do a little side pot, side branch open, strut opening, and repot. And now this concept has come again now, pot, side branch opening, dot, and repot. So there's a lot of different terminologies coming up. And I hope I answered that question, Rafiullah. And then Rafiullah also had a question about, suppose in case of critical disease of left circumflex, distal left main is moderate, and LED had plaque with normal MLA. If you how would you approach if you need to do final kissing balloon because LED is not perfect enough? First of all, you have to cover the LED in these situations. They isolated, for example, let's divide it up. You take the isolated LED osteostenosis and try to stent it. If you do imaging with an OCT or IVUS, there's plaque extension distal left main. You have to do a crossover stenting because what you're going to come back with is restenosis, most likely at the ostium with circumflex, because there's a few strands that cross over, cover the ostium circumflex, and they're nidus for restenosis. So there's no such thing as leaving that alone. You have to do crossover stenting, even if you think LED is near perfectly normal. Next question from Dr. Ehtasham. In my experience, I've seen patients heart failure, low EF, fixed LED is recurrent admission to hospital with heart failure decreases. Would it not be to improve its symptoms so we can do PCF symptoms? I didn't quite understand the question, Ehtasham. I mean, are you trying to say this LED disease, low EF, fix the LED? So let's go back to the surgical literature. Surgical literature said that if you had a patient with low EF, even the dead anterior wall, somehow putting the LED in improved your survival. So there are many retrospective reviews of this, but then superiority was compared to the medical therapy arm. So say if you have multivessel disease, predominant proximal LED stenosis, and that's why they put a levodopa LED graft, it seemed to improve survival. How did it improve survival? You reduced arrhythmic events in the future. That's what the thinking was, even for the dead anterior wall. Was it proven through trials? No, it was not. Okay. If you think about a stitch trial, and initially, the survival curves are very similar to medical therapy, but the benefit was 10 years later. The surgical group is left survival. So, yes, if there's low EF, should you fix the LED? Yeah, but there's no data that by putting a stent gives the same. You need a trial like this for 10 years, like Stitch, to show patient low EF, fix the LED with a stent, and it have benefit. And there's no trial that's going to show you that, and there's no trial coming up to prove this. Then
we have a few. Do you have more questions? We have a few panelists here: Professor Zubair Saab, Nadeem, Rizvi Saab, and Tahir Saab. Your thoughts as well. I guess we can take this question that we have, and after that, thoughts from Tahir Saab and the panelists.
Let's see what's the next question.
Question from Saghir Rashid. Yeah, long question. After left main stenting, it's very scary to think what will happen. A patient stops DAP, as in nearly last 2 years of my interventional training, I've seen around 3 to 4 patients who got PCI proximal to mid-LED more than a year or two ago and came with stent thrombosis after stopping DAP within a week's time. So how long should DAP be continued after left main stenting, and can patient ever be switched to single antiplatelet therapy? What about using ticagrelor alone after a year of DAP, and any role of rivaroxaban? Thanks.
So let me answer the latter part of the question.
So it's basically about DAP, SAPT, post left main PCI, and and timing.
So, so in left main PCI, coming from EBC, a number of retrospective registries have shown that if you stop DAP, we know this in the first month, stent will thrombose. But I think a lot of these registries have suggested 12-month DAPT for complex lesions, including left main, distal left main bifurcation, and multivessel stenting. Now, if you isolate the left main alone, there's a trial that's going to come up, multi-center, multi-country, showing whether 12-month versus a shorter period of DAP would be ideal, okay? So that's the first answer. The second answer is that after 2 years, it's not stent they can thrombose, but then you have to go back and say, hey, was the stent ideally opposed? Was it undersized? I mean, a lot of people probably undersized the stent if you're based on angiogram alone. So all those factors can count in stent thrombosis, okay? But the most important thing to know is that at 2 years if stent is reneutralized, it's probably new atherosclerosis, plaque rupture, and then thrombosis in that area of the stent, okay? So having said that, particularly Europeans have shortened their DAPT strategy, and now they're thinking, and the recommendations are coming up, and there'll be a document coming up soon. I can't talk to you much about the document, but I think in the near future, you think about short DAPT and patients with high ischemic risk, based on DAPT score, you probably suggest some kind of monotherapy. Some of that has made it into the chest pain guidelines, but a clarification will come up soon also. It's that short-term DAPT, for example, the dual therapy for a month or 3 months, and then just dropping everything to one agent only.
As in the guidelines for the early session of DAPT, as been suggested with patients stable ischemic heart disease, you wouldn't apply that to your typical left main patient.
That's not applicable in that group, but that group was never.
So those patients were not included. So that's the, you still continued for at least a year, and we don't have data further out in terms of, So
and use a rivaroxaban? No. I think the recent presentation at TCT, etc., have shown no advantage of using low dose rivaroxaban in long-term patients with stent.
Have you actually considered, just this question came up recently in the group as well, in terms of aspirin allergy, using rivaroxaban as an alternative, if somebody's severe allergy? I mean, aspirin desensitization can be done, and most people do okay on low dose aspirin. But somebody who has the fear of not using aspirin, rivaroxaban 2.5 BID, the arterial thrombosis dose combined with a, clopidogrel or ticagrelor combination. Have you used that?
There's no data supported.
No data to support that, but for aspirin allergic patients.
What I've done is basically use a more potent agent like prasugrel or ticagrelor. Okay.
As a single agent, or what is the second agent you would use with that?
No second agent, just isolated therapy with those drugs.
All right, Tahir Sab, your thoughts, comments, questions?
Tanveer Sab, in patients of left main stenting bifurcation, would it be feasible that you can use a dab in the circ and LED to left main stenting? Is there any role of dab in the circumflex?
Drug-eluting balloon in the circumflex.
So actually, there was a study that's just come out, Eastbourne study, and then there's another study as a registry that a guy knows Ekins Hall from Britain has had about 800 patients, where he's shown that drug-coated balloon in the circumflex and provisional stenting across, they have good results. But there's not a trial. There are just 2 registries showing this, okay? That drug-coating balloon in the side branch is just as fine. Now, Xiaolong Chen has got a trial going on in China right now to show this. The results are not out yet. And the Bifurcation Club is building a trial to do exactly what you've just said. But I think registries have really come out from short registries have shown, yeah, you can do that for your circumflex side branch. But it's not proven through a trial, and trials are needed to prove whether that's the right approach or not. In the US, we don't have any drug-coated balloon available, so we stand or leave them alone.
Zubair Sab, your thoughts and comments? Professor Zubair Sab.
Can you hear me, Nouman?
Yes, we can.
Thank you very much. It was a wonderful lecture, I must say, Tanveer Sab. And welcome to all my friends. Just to summarize for the attendees, especially the junior staff, and a few comments in between. You have taken this talk to 3 parts. First was in the 70s and 80s and 90s, obviously when the interventional therapies were not there, and you just compared medical versus a cabbage, and obviously with stable and unstable patients. And obviously it was proven that cabbage had a better outcome. In 90s, obviously, when there was stent era, initially it was for bailout, and later on just the bare metal stents. There were trials going on, like Bahria trial, comparing, multivessel PCI with Tabba, and then comparing with cabbage, and obviously it proved superiority for cabbage even, So cabbage was there till the last century, But obviously, with the drug-eluting stents coming up in early this century, and especially with this syntax trial, obviously that was I think that was one of the major trials which got everybody into multivessel stenting and left main stenting. And obviously the syntax score along with the STS score, this still stands, So after this syntax trial, people went into it, and with low and intermediate scores, they went ahead with the stenting, and obviously there were results coming, and people were tempted to do more and more. I remember in 90s, whenever a bailout of situation or whatsoever of left main was to be done, I remember it was, first of all, Impala was not there. First of all, people will first of all go ahead with an intra-aortic balloon, first place there, and then they dare to attempt. It was a no-go area, left main, even in the start of this century also. But obviously, it was just for the bailout situations or of a surgically turned down patients. And latest trials, as you have shown, the pre-combat, the Excel, and Nobel. It's such a nice to see the results, the 10-year follow-up, as you have shown, that at 10 years, except for a minor deviation Excel trial, there is no difference in mortality. Obviously, the target lesion revascularization is one thing to look for, but obviously, one again a good thing to that the guidelines have level of evidence is this to be, but obviously the recommendation now has gone from class 3 to 2A for a distal left main. Obviously, for a shaft and ostial left main, we knew it has got a very low target revascularization rate, and mortality benefits are there. It was there to be done, but obviously the real challenge for interventionalists was this distal left main bifurcation and a complex bifurcation. And from class 3 to 2A, obviously, especially in USA, obviously that's a remarkable thing to happen, especially with the short-term and the long-term results of these uh, trials like syntax and pre-combat and the earlier results, 5-year results for this Nobel and Excel trial. One thing which has happened over the years, it's not just the generation of the stents getting up and more decent stents coming with thinner struts. It's expertise also growing up, and then obviously the stent hardware. Initially we would have a stents like 3.5 and maximum to 4, and obviously which won't fix in most of the left mains. But then it came 4, and now you have got this Onyx going up to even 5.5, and recently the Boston scientific people have gone with the dedicated, left main stent like Megatron, which you can even fix out to 6. And as you know, the other best thing which could have happened over the last decade or two is the imaging. The IVUS use with the latest generation stents used in left main, obviously that has really changed the spectrum. But I agree with you. And as a sum up, obviously there are 2 or 3 things which are very important. One thing is your LV function. As you say, I would be very reluctant to do a left main or a triple with the triple vessel disease with the left main with the LV ejection fraction less than 30%. But anything above 45 or 50, obviously I may be still doing it. And the other thing is regarding the diabetes. Obviously, here is in Pakistan and Southeast Asia, obviously, there are so many diabetics and badly controlled diabetics. Obviously, that is one other indication, where I'll go with maybe a cabbage preference. One major concern in our part of the world is the age group where the ischemic heart disease patients present. As you know, in 40s, 50s, people with the young people with severe triple vessel disease left means. Obviously, there for me there comes another indication. Better defer revascularization for some time if we can. We know that there is a high rate of target revascularization in some situations, but sometimes in 40s, I'll always, if possible, with a good ejection fraction, I'll always prefer to do a multivessel PCI left means stenting first, maybe it clicks, or even if it doesn't click, maybe a bypass for the future. That are my thoughts. Thank you very much. And it was a wonderful listening to you. Thank you.
Yeah, thank you, Zubair. So one thing, yeah, in this country,
I believe
we take.
I think we're running out of time to thoughts from Nadeem Saab. Do you have any thoughts, comments? Nadeem Rizvi Saab?
I think that was an excellent lecture. Just a quick thing. I think in Pakistan, we have to look at the locals' perspective. And I think it was an excellent talk, and he's covered, Tanveer Saab's covered everything. I just want to tell you about the financial aspects here. Now, you see, the junior should not take away this message in isolation of what Tanveer has said. This is a holistic approach, and guidelines are there to guide us. Now, there is a person who comes in with a LED tight narrowing, And there is also a tight narrowing in one of the two OMs. A distal OM has got a tight narrowing, let's say, and it's a 2.2 millimeter vessel. Now with the Sehat card and everything, you want to save, and this patient is symptomatic. There's no mortality thing. He's got mid to distal LAD, tight 90% narrowing. They would put a stent in there and leave the OM alone if you just follow the guidelines, because you would say that you're all right, that's probably the one. It's a very small vessel side branch. If they could just balloon it, they would say that there would be restenosis and balloon. But I have seen patients where you leave these side branches to 2.25 millimeter, 2 millimeter plus, but less than 2.5 alone. And instead of just spending some more time and ballooning it and leaving it with a good flow, these patients come back with symptoms, and the symptoms are not due to that original stented vessel. So my take would be that in our environment, patients who come in with symptoms, if you could try and do as much of revascularization as possible and safely, and don't take the just this isolated support of trials to justify not opening up vessels, which will take a little bit more effort and patience.
Yes, I would play the devil's. I would play the devil's advocate on that in a financially constrained environment where it's a class 2B indication with stable ischemic heart disease, why take on the smaller vessels? I would leave them for a situation. If they cause angina, deal with the bigger vessel first, or the more larger territory first. And, if you can, try to get complete revascularization, but, it's up in the air. That's the debate we had before.
The reason, this is what I'm saying. This is what I'm saying. In a patient who's even paid, the government is paying. You are going to ask him to come back. You are giving him symptomatic relief. In my experience, the more you revascularize, the more chances are that he will have symptomatic relief.
Oh, no.
That's the main thing. That's why the surgery is better in giving symptomatic relief as well, if it's properly done in multivessel disease.
It's that reason, or the reason of plaque rupture, the graft covers a lot of the plaque ruptures that happen, but the stents don't. We don't know that what exactly might be the reason for that, but that's a good thought, to try to get complete revascularization as much as you can, whenever you can. And Bashir and Saab, are you online as well? I believe he also joined in. He was he's in US right now. So your thoughts and
yeah, thank you, Nouman. Thank you, Tanveer. I think a great talk. I missed initial part, but I was
thank you, Bashir.
So I think you see, as Nadeem said, I fully agree. There is like a lot of dynamics and financial constraints in Pakistan is totally different. When I came back initially from US, I had to relearn a lot of things, which we, as you know, we don't even think about it, using multiple stands, multiple wires, balloons, and we have to think even if I have to use an extra balloon or extra wire, and let alone extra stand. Now, regarding this use of stents, what Nadeem said, that branches should also be dealt. All of us have seen our patients like so many times. Even if I have patients who have 3 vessel disease and they are doing fine on medical management. And on the other hand, you will have a patient who has maybe branch disease. He ends up having symptoms despite on medical management. So it becomes sometimes very difficult. But I agree. If you can do as much easily as possible, it's fine. But doesn't mean that you are doing distal branches and all those things. Obviously, every stent you put in, you are going to increase the cost, and just ballooning is going to increase the risk of restenosis and all those things. So I personally try to fix the main vessels, and if there is a main bigger branch, more than 2.5 branch, then I would definitely try to fix it. Otherwise, I would leave.
Yeah, I think the visualization
after these,
just last quick
comment on. Yeah, last quick comment on this. The new trial on revascularization is cardiomyopathy. I think it's relevant.
We had a discussion on that already.
Yeah. Okay, so I was just saying that in our perspective, it's very important, because we really need to understand if it is going to help or not, because you don't want to put stents and it's not going to change the mortality, and it's only for symptomatic relief. So that's
yes, and again, that trial had patients who were completely rock stable, kind of with class 2 or less symptoms or angina for heart failure. So in that population, in stable patients, they didn't really show benefit. PCI, again, surgery option with stitch trial is still there. So last question was from Dr. Thank you for your comments. And again, important point, we have to individualize. Some people have angina just from small branch vessel, and you have to take care of everything there. So Dr.
The guideline is not like the Bible, it's just our recommendations, okay?
Yeah, exactly right.
You have to individualize care. But again, so treating side branch disease really has not changed mortality. It may cause improvement in angina or subjective angina, and it depends. You have to individualize patient, but there's a high chance of restenosis if we put a 2 mm, 2.5 mm stent in a small side branch, and the benefit may be lost anyway.
So we have a last question. And that is the nice discussion need to know from panelists: distal left main disease intervention need to cover ostium. What will be the approach? So I think for that, there's no data, I guess, for covering. A question is regarding if you do a distal left main, do you always have to cover the ostium? So as far as I know, there's no data.
Yes.
I guess so if it's a long left main, you could potentially leave it alone. If it's less than 8 mm, I don't know how Shaoling Chen came up with that number, that if it's short left main, cover it, but it's a long left main in completely normal segment, don't have to bring it all the way back to the ostium. There is no data to say one way or the other, but if you have an ostium, if you're covering the stent with the ostium, the flow is more turbulent, versus in the basic science models, if you're not covering it, it's more laminar. But there's no theory that it results in different outcomes as yet. I mean, your thoughts on it, Professor Rab?
Yeah, that's correct. I mean, the thing is that it is a long
this
left
8 mm number. Is there any data on that? I just have some experts. Chen mentioned it actually in one of his talks. I don't know where he came up with that 8 mm.
I think with the left main is short, we tried
the smallest balloon.
Yeah, just a short left main, you cover it all the way. But for the long ones, sometimes you have some these long left.
Provided there's no edge dissection, okay?
Obviously, yeah. So generally, most of us will cover the ostium. Yeah, most of us will cover up to the ostium. Yeah, if you.
Bashir was saying something. Sorry, Bashir. What you just saying?
No, I was just saying that if you bring it to the ostium, then there is always a risk that you might damage the stent at the ostium with a guide catheter. So you have to be very careful. So I think the number that 8 mm is because you will have able to port it and bring the balloon outside. Otherwise, you can have a smaller stent also. So I again agree with that. I only cover the ostium if it has to be, if there is enough room and I can port that area and there's no dissection, I leave it alone.
Basically it was based on the port balloon thing more than anything else, because you had either 5 or 8 mm and the preference was to 8 mm port balloon. And not to forget these ultra thin stents, particularly from Boston, are very, very subjective to longitudinal stent deformation. Your guide catheter gets sucked in, or if you're pulling out a balloon or IVUS catheter, if you're not careful to pull the guide back, they will squash your stent and they'll damage all the work that you've done.
Very careful with all our catheter exchanges and balloon pullbacks during the left main PCI. So on that note, excellent talk and great discussion.
Thank you very much.
And look forward to future interactions with you, Professor Rab.
Inshallah.
Thank you for taking the time out. Thank you all the panelists and attendees who joined. Have a nice weekend. Take care.
Thank you.